let's dive into discussing pain as it relates to arthritis, specifically osteoarthritis. Why do I hurt and how do I beat it? So the first thing I want you to learn is that, and this is the summary statement, for the whole webinar, is that if it hurts to move and it hurts not to move, then you want to move, because there's so many benefits to your physiology from movement. Okay, so if it hurts to move and it hurts not to move, then move. That's the mantra in arthritis. And of course, there's a caveat there that is, move appropriately. Don't overdo it. Don't hurt yourself moving. But I relate it like this: if you have osteoarthritis, like an arthritic knee, say, like the woman in the picture, and if you walk around with a constant pain of 5 out of 10, with 0 being no pain and 10 being the worst pain ever, if your daily pain is a constant 5 out of 10, whether you move or don't move, then move. Because even though the movement isn't hurting you more and isn't helping your pain, isn't reducing your pain, it is helping you in many other ways. That movement helps you physiologically. If you're moving and it takes your 5 out of 10 to a 6, 7, 8 out of 10, significantly worse, then don't move in that way. Okay, so if it hurts to move and it hurts not to move, then move is the general mantra to follow. And the caveat is, of course, be intelligent. Don't move to make your pain worse. Okay, so osteoarthritis is typically called the wear and tear arthritis, or the pain of old age. And I think that old age is a far too commonly used cop-out. And wear and tear actually is as well, because there's probably people watching this video who have arthritic joints. Maybe it's in the knee or the hands or the back, and they don't have the wear and tear excuse. In other words, I played 12 years of football from middle school all the way through college. And if I went into a doctor and said I had knee pain and they x-rayed me and I had some arthritis on my x-ray, they'd say, oh, that's just from wear and tear from 12 years of football. And that might be correct. But there's lots of people walking around with osteoarthritis of the knee that have never played 12 years of football and don't even have a history of any contact sports. So what do we say about their knee? What's their cause? It's not wear and tear, and it's probably not old age. Okay, so we need to not just use trite lines and move on to the next patient. We need to investigate each patient and say, well, why is this knee arthritic when this is a female who's never played contact sports, didn't cheer, didn't tumble, hasn't had a knee injury outside of sports either? So what is causing the degeneration? We want to dive in there. Plus, wear and tear makes you think it's just a physical injury, but wear and tear can come from other things, right? So this person is an example of someone who could have osteoarthritis and knee pain, who is not old, so old age doesn't qualify, at least chronologically, right? And it's not wear and tear from too much activity, right? So this person may have the knee pain and the arthritis because of systemic inflammation from factors other than too much physical activity or age. And an example is what's in his hands, right? Diet can be a large contributor to wear and tear on the joints via driving systemic inflammation. Okay, another kind of indirect form of wear and tear on this person from physical activity would be if he's metabolically unhealthy and that's causing him to be overweight, like 2/3 of the United States is, or obese, like 1/3 of the United States is. Well, that added weight can drive wear and tear on the joints, because if you're 100 pounds overweight, your joints aren't built to be walking around 24/7 with an extra 100 pounds on them. So that could lead to wear and tear. But the wear and tear is the side effect of the obesity or the metabolic dysfunction, the diet in the case of this picture, say. So we want to look beyond just the common scapegoats and dig down to what is causing the arthritis. And I also want to say, just because someone might look obese, like this guy in the picture, 20% of obese people are actually metabolically healthy. So we can't assume that just because the cover looks obese, that it's unhealthy beneath. Okay, we don't want to judge the book by the cover. 20% of obese people are metabolically healthy, so they, would not be the problem in their case. But for the 80% of obese people who are metabolically unhealthy, we want to discover in what ways they're metabolically unhealthy and address them as best we can, so that they can not only lose weight, but take that extra stress off their joints that the weight is causing, and the extra inflammation off their bodies that the weight is causing. So 3 types of pain. One is structural, and that would be, hey, you're playing football and someone tackles you from the side and you blow out your knee. There's a structural form of pain. Or you're not playing football, but you're driving your car and someone T-bones you and you sustain a whiplash injury to the neck, and that can cause pain and ultimately osteoarthritis in the neck. Metabolic pain, kind of like we just talked about with this guy. If you're eating an inflammatory diet and you're overweight, or you've got diabetes or autoimmune disease, or one of the various diagnoses, those would be metabolic drivers of pain. So you weren't hit by a car and you weren't tackled on a field, but you ate gluten, you drank dairy, you smoked a cigarette, or whatever it is. Okay, overconsumed sugary drinks or alcohol or whatever. Those things can drive pain via systemic inflammation. And then neurologic pain is a third form of pain, and we're going to dig into that as well. And that's where you are hurting because your nervous system or your brain learned the pain, even though your knee may not look bad on x-ray. Okay, so if someone goes to a doctor, has knee pain, they x-ray it and say, hey, the knee's fine. They might even MRI it and say, hey, the knee's fine. But the patient still says, but I have knee pain. Okay, that might be a central cause of pain or a nervous system cause of pain, and that would be neurologic pain. And we'll dig into that further. Those are the 3 main drivers of pain. There's also a fourth that we've talked about before, which can be genetic. And we'll talk about that in a moment. But the most common form of arthritis in the elderly is osteoarthritis, and that's the most common form of pain in the elderly. Okay, so if we look at this study here for a moment, I just want to read to you, because this study is talking about the nervous system form of pain in osteoarthritis. Okay, so it's not so much pain because of an injury anymore. The joint may be healed and look fine on diagnostics, but you're still having pain, and it doesn't fit what the knee looks like on x-ray. So, quote, the mechanisms underlying chronic pain states, including osteoarthritis, differ from those underlying acute pain. Okay, so chronic pain is different from acute pain, which I'm sure you've intuited. Okay, in chronic pain states, the nervous system factors often play a particularly prominent role. In many individuals with chronic pain, pain can occur with minimal or no evidence of ongoing nociceptive input. So what that's saying is what I've said a couple of times. In patients with chronic pain, the pain can be there even though there's no evidence of damage to the actual tissue. These same central nervous system processes can augment or magnify pain when there is ongoing tissue damage, as in conditions such as osteoarthritis or autoimmune disorders. The hallmark of centrally driven or nervous system pain conditions is diffuse hyperalgesic state. So that's hyperalgesia, is increased pain response to something that shouldn't be painful, right? So if anyone watching the call right now, unless you're in a heightened pain state, if I just walked up to you and flicked you on the forearm with my middle finger, right? You'd feel that, but you probably wouldn't say ow and pull your arm away in pain. Okay, but if you were hyperalgesic or your nervous system was hypersensitive to the pain, I'd flick you and you'd be like, ah, and pull your arm away, right? And then if you have diffuse hyperalgesia, diffuse means I could flick you anywhere on your body and you would have that response. Okay, so if I flick you in multiple different sites on your body, and you have increased pain response to that, that wouldn't be, the likelihood that I flicked you in the perfect spot where all those places you had multiple injured locations and I hit them all perfectly is 0. Okay. So it's not because all those spots that I flicked are actually injured. It's because your nervous system is hypersensitive to pain. So wherever I flick you, you would be hurt. And that's the diffuse nature or the spread out nature of it. Characteristic symptoms of central pain conditions include pain at multiple sites, fatigue, poor sleep, memory complaints, and frequent mood and anxiety disorders. Okay, so how would we distinguish between a person with osteoarthritis, with pain in the tissues only, so like knee pain because of something occurring at the knee? How would we distinguish that person from someone with knee pain that's coming from the nervous system or central pain? Well, the person with knee pain coming from tissue damage just at the knee will only have issues at the knee, but the person with knee pain that's coming from a central location or from the nervous system may also have pain in other spots, may also say they're tired all the time and not sleep well and be anxious, for example. So the bottom yellow paragraph, while osteoarthritis is generally considered a peripherally mediated pain state, a subset of these patients also manifest centrally driven pain characteristics. So what that says, osteoarthritis is typically pain because of some at the knee or at the elbow or wherever it's happening, something outside the central nervous system. But some patients have a central nervous system characteristic. Thus, osteoarthritis can also be thought of as a mixed pain state and requires a more tailored approach to treatment, with the key being the more tailored approach to treatment. We shouldn't see knee pain and treat everyone the same, right? But if you go into an orthopedist office with knee pain, they're not going to check your blood sugar. They're not going to check your gut or your hormones, right? They're going to examine your knee and give you, an ibuprofen or Celebrex or steroid injection or cream, right? So that might help 4 to 6 out of 10 patients, but then the other 4 to 6 out of 10 patients aren't helped by that. And those patients are probably, they have peripheral neuropathic pain and or central pain involved, right? So the patients that are helped by the simple exam and simple treatments are the ones that only have pain due to, tissue damage. They're kind of the easy cases. But anyone with pain due to nerve damage and or the brain involvement are not going to be helped by the NSAIDs. And so we need the more holistic or functional approach to that person. So I said a moment ago, there's a 4th type of pain, and that can be a gene interplay. Okay, genes play a role in pain, but they're not the whole role. And so we've talked on previous videos, and this is a slide actually out of a previous video I posted before, where we talked about chronic pain could be due to genetic susceptibility to increased inflammation. Okay, so if you look at the left side of the screen where the black text is and it says IL-6, IL-1B, and TNF-A, those are cytokines that code for inflammation in the liver. And so when those numbers increase in the liver makes C-reactive protein, which is medicine's favorite inflammatory marker to test on your blood tests. And if you have high C-reactive protein, you have increased pain, inflammation, autoimmunity, increased risk of cardiovascular disease. And so on the bottom of the screen, you can see a test that I ran on a patient looking at the genes for IL-6 levels and TNF-alpha levels. And so the genes code for the body's production of IL-6 and or TNF-alpha. And so if you have, if we step back, your genes come from mom and dad. So mom gives you one copy and dad gives you one copy. If mom and dad both give you a good copy, you have the normal variant of that gene, and you're not at increased risk of inflammation for that gene. But if mom gives you a bad copy and dad gives you a good copy, now you're at an increased susceptibility for more inflammation from that gene. If mom and dad both give you bad copies, you've got the highest risk of having higher inflammation than someone that has 2 good copies. Okay, so this is how genes can play a role. Is depending on the hand you're dealt from your parents, you could be at a greater risk of being more inflamed. But the way that the genes don't play the whole role is that above genes is a thing called epigenetics, which we've covered in the past, which means your lifestyle, the environment, or your choices impact whether the genetic card you've been dealt is expressed or not. Okay, so you might have 2 bad copies of the IL-6 gene and still have normal inflammation levels because that gene hasn't been expressed or that light switch hasn't been turned on, right? And I've had patients before where, when I first met them, they had this gene, but they weren't overly inflamed. And then something happens in their life, like they're in a major car accident, and now they're more inflamed than they've ever been. And we can't get their inflammation back down to normal like we used to be able to. And that would be an example of an epigenetic switching on or expression of that gene that now you can't always undo. So what would this look like in a patient's case? Well, there was one example I just gave you where the gene wasn't expressed and then an environmental factor led to expression. Or I've had a patient that came in with chronic pain in the shoulders, and he had multiple inflammatory markers lab high. And through his care, we reduced all of them but one. We reduced his TGF beta, we increased his vitamin D and his omega-3s, but his CRP stayed high no matter what we did. He came in at an 8.4. The best we saw was a 7.69. Lab highs anything over 3. Okay. So ultimately, we ran his genetic tests and we saw his IL-6 and TNF alpha were both, he got 2 bad copies of both. So he was more prone to inflammation than someone with 2 good copies of both. And so what that does is that changes our clinical expectation of what optimal for him is in his C-reactive protein, right? He'll never be optimal, which is less than 1, because he's got 2 bad copies of those and they're being expressed. So what we knew at that point is 7.69 is the best we've seen on him. We'll continue to try and get it down, but if we don't, we know, hey, 7.69 is optimal for you. So in the future, if his pain gets worse or he has an accident or something and we retest and he's up to 10 or 11, we know, hey, the best we've seen on you is 7.69, you're at 11, we need to take action to reduce that, right? And the goal is to get it back down to 7.69. So I hope that makes sense for you in that there is genetic contribution and it can impact what our expectations are for optimal lab values. But let's not forget about metabolic pain, because honestly, metabolic pain is going to be the most common driver of people's pain, whether we're talking about arthritis or rheumatoid arthritis, etc. So here's a study from 2018, and it's entitled Targeting the Gut Microbiome to Treat Osteoarthritis Caused by Obesity. Okay, and what this study says is obesity is a risk factor for osteoarthritis. Osteoarthritis is the greatest cause of disability in the US. The impact of obesity on osteoarthritis is driven by systemic inflammation, and increased inflammation is understood to be caused by gut microbiome dysbiosis. So what they're doing here is tying together obesity causes increased inflammation, and having an unhealthy gut also increases systemic inflammation. And so what they wanted to do in this study was take people and say, if we've got obese people with osteoarthritis pain and they've got imbalanced gut microbiome, so maybe they have poor probiotic status and or high bad bug status, if we balance out their gut, how does that impact their obesity and how does that impact their arthritis? And so they started it with mice. For this study, they were studying mice. And so they took obese mice and they gave them fiber that promotes gut bacteria that promote a lean body type. And when they gave those mice the fiber, the obese mice became healthier, right? They had reduced inflammation in the colon, they had reduced inflammation in the blood and the knee, and protection from osteoarthritis. So what this is saying is the gut matters. And like I said before, how many times have you gone to an orthopedist to have your knee looked at and they had you do a stool test to investigate your gut microbiome, right? Or the patients who go to the orthopedist and they get the typical workup and their knee never gets better, well, maybe they need to look at their gut, right? And look at their systemic inflammatory levels, because the knee would be the symptom in that case. And unless you address the cause, the knee is always going to hurt. Here's a study from 2006 called the gut joint axis, cross-reactive food antibodies and rheumatoid arthritis. So this is a rheumatoid arthritis study instead of osteoarthritis, and rheumatoid arthritis is autoimmune. And this is a human study. So they compared 14 patients with rheumatoid arthritis to 20 people without rheumatoid arthritis, considered healthy. And they looked at antibody levels to multiple foods, from dairy to gluten to eggs to fish and pork. And what they found was in the RA patients, there were higher antibody levels against the foods than in normal healthy controls. And so this showed a gut joint axis, or hey, what you eat can impact your level of joint pain and degeneration and function. And so, it's 2023 and I still talk to patients every week who say, I have Crohn's disease and my gastroenterologist says my diet doesn't impact it at all. It's like, how could any human still be saying that? Or any doctor, at least, who supposedly is learned and has read things. Your diet does matter, okay? Positively or negatively, your diet absolutely matters. So this study concluded with the production of cross-reactive antibodies is strikingly increased in the gut of many RA patients. So again, we don't want to just focus on the joints in the rheumatoid arthritis patient, and we don't want to just give them Humira to try and suppress the inflammation and not look for where it's coming from. We should also be saying, hey, what's your diet look like, patient? And do we need to change it? Because if you're eating 3 times a day and you're eating gluten, dairy, eggs, and you're someone who has antibodies to all the 3 of those things, taking Humira is going to do nothing to help you, because 3 times a day you're eating, you're pouring gasoline on that fire by eating those foods. Here's a more recent study on the gut microbiome and the mouth microbiome, which we've talked about multiple times on this channel. And how does the mouth and gut microbiome tie into arthritis? And so first line, the gut microbiome appears to be a significant contributor to musculoskeletal health and disease. So again, if an orthopedist isn't looking at the gut, and the gut is a significant contributor to musculoskeletal health and disease, then they're missing a huge contributor, right? And they might not get all their patients as well as they could, because they're only looking at the elbow or the knee or the toe or the neck and not at the gut. It has been found that the mouth microbiome is involved in arthritis pathogenesis. The composition of the microbiome and its functional implications have been associated with the prevention of bone loss and reducing fracture risk. The link between gut-mouth microbiome and joint inflammation in animal models of arthritis has been established, and it's now receiving increasing attention in human studies. Recent papers have demonstrated substantial alterations in the gut and mouth microbiome in patients with rheumatoid arthritis and osteoarthritis. These alterations resemble those established in systemic inflammatory conditions, which include decreased microbial diversity and a disturbance of the immune system. An association between the abundance of oral Porphyromonas gingivalis and intestinal Prevotella in RA patients compared to healthy controls has been clearly established. So what that's saying is patients with RA have higher levels of P. gingivalis in the mouth, which is a pathogenic bacteria in the mouth, and Prevotella copri in the gut. So they have higher levels of potentially pathogenic bugs in the mouth and gut than healthy controls. The changes in decreased diversity of mouth and gut microbiota seem to play an important role in the pathogenesis of rheumatoid arthritis and osteoarthritis. So how many times has someone with knee pain been to an orthopedist and the orthopedist asked them about their oral hygiene? And do they floss and do they brush every day, right? So this is connecting those dots. And the table on the right-hand side is showing you RA patients and how the mouth bugs and the gut bugs differ from healthy patients. So for example, the first study on top with RA, in the mouth, they had increases in multiple different bugs on that list compared to healthy controls. And in their gut, they had decreases of multiple key probiotics. Okay, so again, we don't want to ignore the rest of the body just because the knee hurts. Here's a picture of the gut joint axis, combining a couple of different studies that we've talked about. If we put it in a picture, it looks like this, where in the gut, if you have dysbiosis or imbalanced bugs, that can trigger the immune system. And if the immune system makes antibodies to those bugs, those antibodies may also cross-react with self-tissue, okay? So the antibodies fit receptors on the bugs that are similar looking to our joints. And so if there's the potential for those antibodies to bind to our joints thinking it's the bug, and now you've got inflammation and an autoimmune attack, or your immune system attacking your joint because it thinks it's the bad bug. So that's the gut joint axis. That's cross-reactivity, or as I talk about in my book, a nerdy term called molecular mimicry, where because your joint looks close enough to the bug, the immune system might not tell the difference, and now you're attacking yourself. So that's all the nerdy minutia, but let's get to the practical stuff. What can we use naturally to reduce pain from osteoarthritis, rheumatoid arthritis, just pain in general? And there's lots of options, and there's lots of studies supporting these options. So fish oil is one great option. Fish oil is anti-inflammatory, it's anti-clotting, it's blood thinning, it's pain blocking in multiple ways. And it is an omega-3 essential fatty acid. And the fact that it's essential means our body can't make it. So unless we eat it, we don't get it. Okay. And many people in the United States are deficient in omega-3s, and the omega-3s are the anti-inflammatory component to fish oil. So you need to be getting it, whether that's from eating wild caught fish or supplementing or doing both. Whether or not you're in pain, you need it. It's essential. And again, because it's essential, the fact that it's labeled essential means we can't make it. So we must consume it or we don't get it. Turmeric, curcumin, highly anti-inflammatory, many benefits to this compound. And in regards to relieving pain, it's big time anti-inflammatory. And I'll show you a study in a moment where they put it up against diclofenac, which is a non-steroidal anti-inflammatory drug, or NSAID drug, and it has equal efficacy at reducing your pain and inflammation without the side effects that the NSAIDs bring. So that's a great option. Resveratrol is another great option for natural anti-inflammatory and helping with pain. And this is one that many alcoholics justify their addiction with, right? They say, I'm drinking the wine because it's got that stuff that grapes have, right? That helps reduce inflammation. Yes, your wine does have that, but you're probably drinking more than you need. Dr. Mark Houston is one of the top functional cardiologists in the country. He practices in Nashville, Tennessee. He's a medical doctor, cardiologist that practices functional cardiology, as I said. And I did a seminar with him last year, and he said that males need, or the resveratrol that that would be beneficial for you, males can get from 6 ounces of red wine a day, and females can get from 3 ounces of red wine a day. So beyond that, you're just rationalizing your addiction, right? Wink wink. Boswellia is another great anti-inflammatory and pain reliever. This is also known as frankincense. And I'll show you a study in a little bit where this also goes head to head with NSAIDs and is equal in terms of its benefit. Chinese skullcap is a great anti-inflammatory, can help with pain. Probiotics can help with arthritic pain. How? Well, we just talked about the gut joint axis, looking at multiple studies, right? And if you're lacking probiotics, that drives inflammation in the gut, which can lead to the arthritis pain. So we want to have good optimal probiotic levels, and we also want to feed those probiotics with fiber, because fiber is the prebiotics, or the food that the probiotics eat. You've all probably heard of glucosamine and chondroitin at this time, and those are supplements, or I guess compounds that support cartilage health and hydration of lubrication of joints. Collagen promotes joint integrity. Gelatin, if it's organic, promotes joint integrity. And then CBD is very effective as a pain reliever, at least in cancer, but probably for arthritic pain as well. It's also good for anti-anxiety and sleep and other things. Here's the study I referenced about curcumin beating NSAIDs for knee osteoarthritis. So the conclusion of the study was curcumin has similar efficacy but better tolerated than diclofenac among patients with osteoarthritis of the knee. So it's as good at helping with the knee pain, but better in terms of potential side effects. So check out curcumin. Here's boswellia or frankincense for osteoarthritis. So this study looked to, well, let's look at the top line. Osteoarthritis is the commonest form of inflammatory joint disease. Unfortunately, to date, there is no appropriate treatment for osteoarthritis. Okay, that's what this paper is saying. And I guess we should qualify it as there's no appropriate medical treatment. So these guys were wanting to investigate, well, let's look at boswellia because it's considered a potent anti-inflammatory, anti-arthritic, and pain reliever. So could this be an appropriate treatment? They looked at 545 patients and used boswellia. And based on their study, boswellia and its extract may be an effective and safe treatment option for a patient with osteoarthritis. And the recommended duration of treatment and its extracts is at least 4 weeks. And I think this is important to point out that medications often work faster than natural products. And the reason for that is medications inhibit a larger amount of physiology than natural products. So in order to be classified as a drug, you have to inhibit up to 90% of physiology. And so if you take a drug that does that, then it's probably going to reduce pain along the pathway on which it works a lot faster than something natural like boswellia. The problem is that if you take a drug, that drugs can only be created to target one pathway. Okay, so if you take that drug and it only works on that pathway, but working on that pathway doesn't reduce your pain, that drug doesn't help you. You're still in pain. Even if it helps you, it still has side effects. Whereas the natural products affect multiple pathways and they don't shut them down as thoroughly, so the side effect profiles are less. But because they don't shut them down as thoroughly, it may take longer to work. And so if you only take it for a couple of days and you don't have less pain and you give up, you might say, oh, boswellia doesn't help me. That's malarkey, right? And it's like, well, no, this study said you have to try it at least for 4 weeks. So if you give it 4 to 6 weeks and it hasn't helped your pain, well then, yeah, you can move on and think, okay, maybe boswellia isn't what I need because the pathways it works on maybe aren't the pathways that need to be worked on in you. And that feedback is a clue. So, whether it works or doesn't work, that's a clue in your case to understand what physiology actually needs to be addressed to impact your pain. And there's many other studies showing many other natural alternatives that you could use for pain relief. And so this study is written by Joseph Maroon, who is the neurosurgeon for the Pittsburgh Steelers. So, that's pretty mainstream in terms of where this information is coming from. So it's, don't let people call you a quack if you're trying to address your pain naturally, because hey, even the Steelers are trying to do it. Here's another study looking at supplements for treating osteoarthritis. So this study lists, they looked at many studies to compare supplements to placebo for decrease of hand, hip, or knee osteoarthritis. And out of 69 studies they looked at, 7 supplements really stood out. They were collagen, passion fruit peel extract, curcumin, boswellia, pycnogenol, and L-carnitine. So a couple that we've said already and a couple newer ones. So again, just showing you that there's many options. And if you try one and it doesn't work for you, try another, because the one you tried that didn't work might work on a pathway that you actually don't need worked on. You might have to address another pathway with a different one. And if that's too much for you to think about, then, working with a functional medicine doctor who can tease out those pathways for you could save you a lot of mental anxiety. So movement. So those were the oral things you could take, supplements, herbal compounds, things like that. Movement can also be a pain reliever. And as we opened up with tonight, we said, if it hurts to move and it hurts not to move, then move, right? All else being equal, if your pain's going to be 5 out of 10, whether you sit here or you go for a run, you should go for a run, because the run's going to provide you with a bunch of other benefits body-wide. We can potentially use sound as a pain reliever. Here was a study put out in 2022 looking at how sound reduced pain in mice. And what the scientists did was they studied whether sound would reduce pain in mice by impacting mechanisms in the brain, and they found that it did. And what was interesting is that any sound reduced the pain. Okay, so in the study they tried classical music, and they tried white noise, and they tried rock music, and basically it didn't matter whether it's classical, white noise, rock music, any sound. It was just the sound itself that fired the circuits to reduce pain. And the other interesting piece was the sound was like background noise, and it was really background noise behind background noise. So it doesn't have to be super loud. It's like on to the perceptible level, so that you could hear it if you're really trying to hear it, but you may not hear it if you're busy, doing chores or whatever, but your brain hears it. So you can kind of turn it on in the background and help yourself. And the researchers ended with saying, okay, it's cool that any sound does it. Now we do want to research more thoroughly, though. Do certain sounds and frequencies work better? And so that research is forthcoming. But I suspect classical music will probably outperform rock music or white noise, because it tends to in other studies that look at it for health and brain effects. 2 other frequencies I'd like to remind you of, because we've made videos on these in the past, but solfeggio frequencies are frequencies that come from way back in the Hebrew tradition, and there are different frequencies of sound that promote healing of, say, physical pain versus emotional pain versus all kinds of other issues. So if you just type in solfeggio frequencies in YouTube, you'll find lots of channels where you could just put those on in the background and go about your chores. Nogier frequencies are frequencies that were discovered by a neurologist named Paul Nogier from France. And whereas solfeggio frequencies are numbered, Nogier frequencies are lettered. He called them A, B, C, D. And again, if you search these on YouTube, you'll be able to find channels that play these, and his different frequencies address different pain and different goals. So again, find the frequency that matches up with your goal and play that in the background. And hey, the worst case scenario is it doesn't help you. But if it does help you, then you still folded your laundry. You just had less pain because you added this to what you were doing. And then lastly, light can be a pain reliever, and light in the form of laser. And that can be red light or near infrared light. Red light is visual, near infrared you can't see, but has multiple benefits. And there's thousands of studies on low-level laser therapy, or cold laser as it's called, and its benefits. And you can see in the image here multiple of those benefits. In the right-sided pictures, I was using my lasers on my son's foot because he jumped from a high perch and hurt his foot. So we were lasering his foot in that picture. And then on the right there, I'm lasering a patient's lungs from behind that had COVID. And so there's multiple studies on COVID and red light and near infrared light being effective for that. How so? It increases circulation, increases oxygenation of tissue, decreases inflammation, all kinds of benefits. So if you have access to light as a pain reliever, you could do that by going to a clinic that has lasers. There are red light devices available for consumer purchase. You could go in an infrared sauna. You could go out in the sun. There's lots of different ways to get light exposure, both paid and unpaid. So if you're out there and you have osteoarthritis or rheumatoid arthritis or any of the different arthritic diseases, and you've never considered natural ways to reduce your pain, you've just relied on NSAID medications or steroids, I'd encourage you to look deeper into these options as pain relievers. And if they're relieving your pain, or while they're relieving your pain, that's buying you time to further investigate, hey, is it something from my diet that's driving the inflammation? Is my gut microbiome a mess? Is my oral hygiene poor, causing a poor mouth microbiome that I need to clean up? You know, what's the real cause to why I'm inflamed and having these joint issues? And functional medicine is a healthcare paradigm that can help you untangle that web and help you reach your optimal health and quality of life. So check that out, whether reaching out to us at functionalmedicincharlotte.com or searching functional medicine in your locale and finding a doctor that you vibe with.